Modern phonocardiography has resulted in improved standards of auscultation, and it is now possible for the trained clinician to hear and appreciate the various heart sounds and murmurs with a marked degree of accuracy. It is the purpose of this record to describe and illustrate the majority of sounds and murmurs which may be heard in normal and pathological hearts. The important effect of respiration on the intensity or position of right-sided events has made the recording of breath sounds unavoidable in some instances. The listener is advised to ignore these breath sounds as far as possible. Let us first consider the heart sounds. The normal first heart sound has two main audible components which are due to mitral followed by tricuspid valve closure. Both components can usually be heard in normal subjects at the lower sternal area and apex. This reduplication of the first heart sound may be more obvious during inspiration, when increased flow from right atrium to right ventricle causes a slight delay and increased intensity of the tricuspid component. A wide splitting of the first sound occurs in right bundle branch block, as the late activation of the right ventricle results in a delay of tricuspid closure. Here is an example of a clearly split first heart sound recorded at the lower sternum in a 5-year-old child. The child is breathing, and a sinus arrhythmia is present. You will hear the two components of the first sound, a short, soft, innocent systolic murmur, and a normally split second heart sound. Attention should be focused on the first heart sound. A more narrowly split first heart sound is now illustrated. The recording is that of a 22-year-old man taken at the apex during expiration. A loud physiological third heart sound is audible after the second sound. The intensity of either component of the first sound depends largely on the respective positions of the mitral and tricuspid valves at the time of onset of ventricular systole. Thus, with stenosis of these valves, or in the presence of a short PR interval or a tachycardia, the valve cusps are still wide open when the ventricle starts contracting, and the first heart sound is consequently loud. Here is an example of the loud mitral component of the first heart sound commonly heard in mitral stenosis. A loud and slightly delayed tricuspid component of the first heart sound is often present in atrial septal defect. In this condition, there is a left-to-right shunt at atrial level, and thus a large flow through the tricuspid valve. Here is an example recorded in the third left intercostal space in an 11-year-old boy. The first heart sound has a soft mitral component followed by a delayed and louder tricuspid component. The patient is breathing, and a sinus arrhythmia is present. A pulmonary ejection systolic murmur and widely split second heart sound typical of atrial septal defect can be clearly heard, but attention must be focused on the first heart sound. The soft mitral component will only be heard if the listener concentrates on the period immediately preceding the obvious and quite loud tricuspid component. Here is the recording again. By a similar analogy, the first sound is relatively soft, with a prolonged PR interval and with a bradycardia, as the atrioventricular valves have had time to float into apposition before the onset of ventricular systole. Complete heart block, ventricular tachycardia, and atrial fibrillation thus have a varying first heart sound, since ventricular systole will occur with the valves ranging from wide open to nearly closed. Listen now to the varying intensity of the first heart sound in a 53-year-old man with atrial fibrillation due to thyrotoxicosis. Actual deformity of an atrioventricular valve may also affect the intensity of the first heart sound, irrespective of the position of the cusps. For example, the mitral component is usually soft in mitral incompetence, probably due to the shortening of the valve cusps and chordae tendinii, both of which prevent normal apposition during ventricular systole. The next recording, taken at the apex in a 17-year-old girl with mitral incompetence, shows a virtually inaudible first heart sound. Concentrate on the period immediately preceding the onset of the loud systolic murmur. The second heart sound also has two components, both of which should be audible in most normal subjects. The first component is caused by aortic valve closure, and the second by pulmonary valve closure. These are frequently referred to as A2 and P2 respectively, and this abbreviation will be used in future on this record. It must be clearly understood that P2 does not refer to the second sound in the pulmonary area, but to the pulmonary component of the second heart sound, irrespective of the site at which it is heard. Similarly, A2 refers to the aortic component of the second sound wherever it is audible. Due to the higher pressure in the aorta as compared to the pulmonary artery, aortic closure is louder than pulmonary closure, and it is usually only the aortic component of the second heart sound which is normally present over the whole precordium. Listen again to the recording of the normal heart with the loud physiological third heart sound. It is taken at the apex. Only A2 is audible, and thus the second sound appears single at this site. The softer pulmonary component is often audible only in the second left interspace, and consequently the normal reduplication of the second heart sound is usually best heard at this site. Whereas the timing of aortic closure is for practical purposes unaffected by respiration, the increased stroke volume of the right ventricle after inspiration results in delay of pulmonary closure. Thus the normal second sound is clearly split in inspiration, but apparently single in expiration. This is illustrated by a recording taken in quiet respiration in a 7-year-old child with a normal heart and innocent systolic murmur. As a sinus arrhythmia is present, the heart rate is faster after inspiration, and this can be used to time the phases of respiration. During inspiration, the second heart sound is clearly reduplicated, but appears single immediately after expiration. Conditions such as aortic stenosis or left bundle branch block, which cause delay of aortic valve closure, will result in so-called paradoxical splitting of the second sound. In other words, the second sound is split during expiration, when P2 precedes the delayed A2, whereas with inspiration, P2 moves later as usual, and consequently the degree of splitting is either decreased or abolished at this time. The variations in timing and intensity of the components of the second sound are of extreme importance in the assessment of systolic murmurs, and throughout this record reference will be made to the character of the second sound. Pressure changes in the aorta and pulmonary artery are perhaps the main factors influencing the intensity of the respective components, but other features, such as abnormal valve cusps, the thickness of the chest wall, and changes in position and size of the great vessels are also of importance. Some examples of alterations in the second sound will now be played. The first is a 52-year-old man with marked aortic incompetence and some stenosis. The recording is taken in the fourth left interspace, and both systolic and diastolic murmurs are well heard. Neither component of the second heart sound is audible. The pulmonary component is delayed and soft in isolated pulmonary stenosis, but it is usually audible. This is illustrated by the following recording at the pulmonary area in a 28-year-old woman with mild pulmonary stenosis. The pulmonary systolic murmur and aortic valve closure are loud, but the delayed and softer P2 will only be heard if the listener concentrates on the period after aortic closure. The time interval between the two components is 0.06 seconds. The pulmonary component can be more easily heard when the recording is slowed to half the normal rate. Here it is at normal speed again. In cases of very severe isolated pulmonary stenosis, P2 can be delayed as much as 0.14 seconds and will then seldom be heard by the clinician, though a small vibration may be seen on a phonocardiogram. In this 17-year-old girl with fairly severe pulmonary stenosis, the pulmonary component is delayed 0.10 seconds, and although this was heard clinically, we have been unable to reproduce the sound on this record. Only the long pulmonary systolic murmur and aortic closure can therefore be heard. In contrast to isolated pulmonary stenosis, pulmonary valve closure is seldom audible in Fallot's tetralogy because a large proportion of right ventricular output is diverted through the associated ventricular septal defect and pulmonary flow is considerably reduced. In this recording, at the pulmonary area of a patient with Fallot's tetralogy, the second heart sound is single, and only A2 is heard after the systolic murmur. In atrial septal defect, because of the increased pulmonary flow, P2 is delayed, loud, and may be virtually unaffected by respiration. The next recording, taken in natural respiration, illustrates this widely split, fixed second heart sound in such a case. Now listen to the same case with the breath held in full expiration. The loud pulmonary component is delayed to 0.04 seconds after the softer aortic component. The forward flow into the aorta is reduced in severe mitral incompetence, and thus aortic closure occurs earlier and is slightly decreased in intensity. This results in wide splitting of the second sound, even though the pulmonary component is moving normally with respiration. The next recording is that of a 21-year-old man with severe mitral incompetence. It is taken at the pulmonary area during natural respiration. The first sound is inaudible, the regurgitant systolic murmur referred from the apex is well heard, and the second sound is widely split with a soft aortic and fairly loud pulmonary component. During deep inspiration, all sounds tend to become softer because of the increased distance between the heart and the chest wall, but the usual increase in splitting of the second sound can be noted. The third heart sound is a low-pitched sound which occurs during the phase of rapid ventricular filling and is probably caused by a vibration of the ventricular muscle. It may arise in either ventricle and varies from 0.09 to 0.21 seconds after aortic closure. A physiological third heart sound is a common finding in children and young adults, but is rare beyond the age of 40 years. A sound which is exactly similar in pitch, timing, and intensity may be present in diseased hearts, and it is then usually referred to as a protodiastolic or rapid-filling gallop sound. Here is the example of a normal third heart sound in a young adult. The low-pitched sound is quite loud and occurs 0.13 seconds after aortic closure. A pathological third heart sound is often present in conditions in which there is a state of ventricular diastolic overload, such as myocardial disease or failure. In mitral incompetence and high output states, such as anemia and thyrotoxicosis, the myocardium is relatively normal, and the third heart sound under these circumstances is probably mainly caused by rapid ventricular filling. The next recording illustrates a fairly soft third heart sound in a 45-year-old patient with mitral incompetence. It is taken at the apex in expiration, and atrial fibrillation is present. The second heart sound is almost drowned by the loud pansystolic murmur, with the result that the soft third heart sound, which occurs very soon afterwards, may be mistaken for the second sound. A very short mid-diastolic murmur follows the third heart sound. The interval between the soft second and third heart sounds is 0.10 seconds, and in order to hear them, the listener should concentrate specifically on this part of the cardiac cycle. The so-called early diastolic sound of the constrictive syndrome is probably similar in mechanism to the third heart sound, but due to the constricted ventricular wall is louder, higher pitched, and occurs earlier in diastole. The greater the degree of constriction, which may be either pericardial or myocardial in origin, the earlier the sound will occur. A loud early diastolic sound is heard in this recording of a 40-year-old man with severe constrictive pericarditis. It is taken at the apex in expiration. The first heart sound is loud, which is not uncommon in constrictive pericarditis, and the loud early diastolic sound follows the softer second heart sound. The interval between the two is 0.08 seconds, which is too early for a third heart sound. The fourth heart sound, atrial or presystolic gallop sound, is probably also a ventricular filling sound produced by a vibration of the myocardium, but is dependent on atrial systole for its occurrence. This low-pitched sound occurs when the atrium contracts against a raised end diastolic pressure in the ventricle, and is never heard in normal hearts unless a first-degree heart block, that is, a prolonged PR interval, is present. Left-sided atrial sounds are commonly present in hypertensive and ischemic heart disease. Here is an example in a 40-year-old man with systemic hypertension. The low-pitched atrial sound is heard shortly before the first sound, and the cadence is that of a gallop rhythm. After clinical improvement or lowering of the blood pressure in hypertension, an atrial sound does not just fade, but moves closer to the first heart sound and is eventually lost in it. When only a short interval separates the atrial and the first sound, the cadence is that of a split first sound rather than a gallop rhythm, and the differentiation may then be difficult. The recording of the atrial sound will now be replayed, and immediately afterwards a recording of the same patient after his blood pressure had been lowered. The interval between the atrial and first heart sound is then less. A right-sided atrial sound may occur in right ventricular failure or duress, and is not unusual, for example, after pulmonary embolism. If both an atrial and a third sound are audible, a so-called quadruple rhythm results. In the presence of a tachycardia, it is often difficult to know whether a gallop rhythm is caused by the addition of a fourth heart sound, a third heart sound, or by a summation of the two sounds. In such instances, the term summation gallop is used. Here is an example of a summation gallop arising from the right ventricle in a 20-year-old man with pulmonary hypertension due to repeated pulmonary emboli. The heart rate is 105 per minute, and the sounds are recorded at the lower sternal area. The first part of the recording is taken in held expiration, and a loud first, followed by a softer second sound, and gallop sound can be heard. During the recording, the patient will be heard to breathe in, after which both the first heart sound and the gallop sound are markedly increased in intensity. An increase in intensity after inspiration is typical of a third or fourth sound arising in the right ventricle. This recording will now be repeated. Remember that the sounds can be timed from the first heart sound, which is the loudest of the three sounds during the early part of the recording. A systolic click is a high-pitched, somewhat clicking sound which occurs during ventricular systole. Systolic clicks will be considered in two groups, firstly early or ejection clicks, and secondly mid and late systolic clicks. Early systolic clicks occur very soon after the first sound and are caused by the ejection of blood into either a dilated aorta or pulmonary artery. An example of an aortic ejection click is provided by a 9-year-old girl with familial hypercholesterolemia, mild aortic stenosis, and radiological evidence of a dilated ascending aorta. The recording is taken over the aortic area, and the breath is held in expiration. The click will be heard just after the first sound and can be distinguished from a split first heart sound by its high-pitched clicking quality. Mid and late systolic clicks are often extracardiac in origin, but may also occur in association with the late systolic murmur of mild mitral incompetence. Here is an example of a proven case of mild mitral incompetence in a 21-year-old man with a mid-systolic click. The recording is taken at the apex during expiration. The first sound is soft and is not heard on the recording. The associated systolic murmur starts before the click and then accentuates and becomes higher pitched between the click and the second heart sound. The timing of the click and systolic murmur become more obvious when the recording is slowed to half speed. And now at normal speed again. Extracardiac systolic clicks, often multiple, may occur in mediastinal emphysema and pneumothorax, or may be due to pleuropericardial tags. An example will now be played of a loud, late, somewhat lower-pitched systolic click, immediately followed by a soft murmur which is probably also extracardiac in origin. The murmur occupies the interval between the click and the second heart sound. The recording is taken at the lower sternal border. Here is the same recording played at half speed. The first sound, loud late systolic murmur, and both components of the second sound should all be heard. The recording will now be played at normal speed. We must now consider the important subject of systolic murmurs. Intracardiac systolic murmurs can be classified into two main types according to the classification introduced by Leatham in 1952, namely ejection and regurgitant murmurs. Regurgitant systolic murmurs are caused by flow of blood from a high to a low pressure chamber. They are usually pansystolic and continue up to or just beyond the relevant component of the second heart sound of the ventricle concerned. For example, in mitral incompetence, the murmur extends up to or just past the aortic component of the second heart sound. Irrespective of intensity, a regurgitant systolic murmur is always indicative of a pathological heart, and signifies either mitral incompetence, tricuspid incompetence, or a ventricular septal defect. Here is a recording of a typical pansystolic murmur of mitral incompetence in a 21-year-old man. The murmur is grade 4 in intensity and extends right up to the soft second heart sound, which is followed by a third heart sound and short mitral diastolic murmur. Regurgitant systolic murmurs due to ventricular septal defects are usually loudest at the lower left sternal edge. The intensity of the murmur is related to the velocity of flow across the defect, and murmurs of grade 4 intensity may be produced by quite small defects. Here is an example of the characteristic pansystolic murmur of a ventricular septal defect with normal pulmonary artery pressure. The murmur is crescendo-decrescendo and extends up to A2. The patient is breathing, and the second heart sound is normally split with inspiration and closes with expiration. P2 is slightly increased in intensity due to increased pulmonary blood flow. A sinus arrhythmia is present. Minute ventricular septal defects with left to right shunts of less than 10% may occur. The murmur in this type of defect is atypical in that it is short, does not extend to the second heart sound, and may therefore resemble an ejection systolic murmur. The next recording is of a 13-year-old girl with this atypical murmur. By dye dilution techniques, she was shown to have a left to right shunt of 8%. A sinus arrhythmia is present. The systolic murmur can be heard to end well before the second heart sound, which is normal in intensity and splitting. This murmur must be distinguished from the short regurgitant murmur present in some cases with large defects but severe pulmonary hypertension. The second heart sound in that type of case is narrowly split with accentuation of P2, and other signs of pulmonary hypertension are present. Regurgitant systolic murmurs due to tricuspid incompetence are also usually loudest at the left sternal border, but have the typical inspiratory increase in intensity shown by all tricuspid murmurs. An example of this will be shown later together with tricuspid diastolic murmurs. Ejection systolic murmurs arise from the aortic or pulmonary valve and are caused by one or more of the following factors. 1. Stenosis of the valve. 2. Abnormality of the valve without stenosis. 3. Increased flow through a normal valve. 4. Dilatation of the vessel distal to the valve. Ejection systolic murmurs are crescendo-decrescendo and always end before the component of the second heart sound of the side of the heart from which they arise. Thus all aortic ejection systolic murmurs end before aortic valve closure, while pulmonary ejection murmurs may extend past aortic closure, but always end before pulmonary valve closure. Ejection systolic murmurs due to scarred valves, increased flow, or dilatation of the vessel are relatively short and accentuate in early systole, whereas those due to stenosis of the valve are longer and accentuate in mid-systole. The character of the second heart sound is of major importance in the assessment of the significance of an ejection murmur. This example shown previously of the patient with mild pulmonary stenosis shows a long pulmonary ejection murmur extending up to A2. P2 is delayed 0.06 seconds after A2 and is decreased in intensity. Here is a recording at the pulmonary area of the patient with severe pulmonary stenosis and markedly delayed and very soft pulmonary component of the second heart sound. The harsh ejection murmur extends just past A2. P2 cannot be heard on the recording but was present clinically. The next example appears similar, but the murmur is slightly shorter and ends before A2. The patient is a case of phallus tetralogy, and the second heart sound in this case is single and the pulmonary component absent. The intensity and length of the pulmonary ejection murmur in phallus tetralogy vary inversely with the severity of the stenosis. In severe cases, the pulmonary ejection murmur is soft and short, as most of the right ventricular output passes through the ventricular septal defect. The pulmonary ejection systolic murmur present in atrial septal defect is due to increased blood flow across a normal valve. This recording at the pulmonary area in the 14-year-old boy is taken in expiration. The second heart sound is widely split with accentuation of the pulmonary component. Here are two examples of aortic ejection murmurs. Both are taken in expiration at the aortic area, and only the aortic component of the second heart sound is heard. The first is of a 35-year-old woman with moderate rheumatic aortic stenosis. The murmur is harsh and fairly long. A2 is softer than normal. The second is of a 19-year-old girl with familial hypercholesterolemia and probable atherosclerosis of the aortic valve. There is no stenosis present, and the murmur is short and A2 normal. In order to appreciate the shortness of this murmur, due to slight scarring of the valve, as opposed to the long murmur of a stenotic valve, this recording will now be slowed. Now listen to the long pulmonary ejection murmur of the girl with severe pulmonary stenosis. The systolic murmur follows the fairly loud first half sound and extends past the relatively softer A2. There are two other types of systolic murmurs of importance, but which are of debatable origin and are therefore considered separately. The first is the late systolic murmur, which may be due to slight mitral incompetence or may be entirely extracardiac. Here is the recording heard previously of the man with a mid-systolic click and late systolic murmur due to mild mitral regurgitation. Now you will hear another example of a late systolic murmur, but without a click, and also due to minimal mitral incompetence. The patient is a 9-year-old girl. The recording is taken at the apex and illustrates well the late beginning of the murmur, which extends up to the second heart sound in a crescendic manner. The first heart sound is clearly audible. The second systolic murmur, which has not been definitely classified, as its precise origin is uncertain, is the common vibratory or twanging string murmur of childhood. This short, rather low-pitched musical murmur is usually loudest at the apex and left sternal border. It is possibly a truly innocent aortic ejection systolic murmur. Here is an example in an 8-year-old child. The murmur is grade 2 in intensity and occupies only the first half of systole. It has a definite musical quality. We now come to the consideration of diastolic murmurs. Early diastolic murmurs start immediately after the aortic or pulmonary component of the second heart sound and are indicative of aortic or pulmonary incompetence respectively. Aortic incompetence is usually due to structural deformity of the valve, as in rheumatism, syphilis, atherosclerosis, and congenital bicuspidism. The murmur is high-pitched, best heard in expiration, and is usually loudest at the left sternal border, but may be louder or only audible at the aortic, pulmonary, or even apical areas. The length of the murmur is some indication of the degree of regurgitation. An associated aortic ejection murmur is almost always present. Here is a recording taken at the left sternal border of a patient with fairly severe rheumatic aortic incompetence and moderate stenosis. The second heart sound cannot be heard, but there is a slight pause between the systolic murmur and the long, loud diastolic murmur. A characteristic high-pitched musical aortic diastolic murmur may occur in association with rupture or eversion of a valve cusp. Here is an example of this cooing dove or seagull murmur. The patient is a 35-year-old man with a ruptured cusp due to subacute bacterial endocarditis. The second heart sound is inaudible and the systolic murmur is very short. That recording, which was taken at the left sternal border, differs slightly in pitch from the next one, which was recorded at the pulmonary area. Functional aortic incompetence is less common, but may be found with dilatation of the aorta, as in medianecrosis or with severe hypertension. When associated with hypertension, the murmur is often low-pitched and short, and A2 is loud. Pulmonary incompetence is usually functional and results from dilatation of the pulmonary artery, which may be idiopathic, but is more frequently secondary to pulmonary hypertension or to markedly increased pulmonary flow with large left-to-right shunts. Organic pulmonary incompetence is usually due to a congenital abnormality, as rheumatic involvement of this valve is extremely rare. This example is of a patient with mild congenital pulmonary stenosis who developed pulmonary incompetence following an attack of subacute bacterial endocarditis. The diastolic murmur is fairly short and follows the delayed and softer pulmonary component of the second heart sound. Here is a recording taken at the pulmonary area of the rare abnormality of congenital absence of the pulmonary valve cusps. The patient is a 34-year-old woman. This low-pitched murmur of severe isolated organic pulmonary incompetence characteristically occurs rather late and may simulate a mid-diastolic murmur arising at an atrioventricular valve. Only A2 can be heard, as P2 is of course absent in this case. The systolic murmur is soft and short. Listen again to this murmur recorded at a slightly lower frequency. Mid-diastolic murmurs arise at the atrioventricular valves and may be functional or organic. First, let us consider mitral mid-diastolic murmurs of organic origin, the most frequent cause of which is rheumatic disease. The murmur is low-pitched and rumbling and is best heard at the apex in the left lateral position. In some cases, it is only audible well outside the apex, even as far as the posterior axillary line. The auscultatory signs of mitral stenosis vary with the severity of the stenosis and the state of the valve cusps. The diastolic murmur in tight mitral stenosis is long, and if sinus rhythm is present, there is presystolic accentuation before the first heart sound. The terminal crescendic murmur is due to flow through the mitral valve following atrial contraction. It is also present in mild degrees of stenosis, but the mid-diastolic murmur in this instance is short and fades off before the presystolic murmur. The first heart sound, as was mentioned previously, is usually loud and snapping, but may be soft if the valve cusps are thickened or calcified. If the valve is pliable, the mid-diastolic murmur is usually preceded by a high-pitched sound, the so-called opening snap of the mitral valve. This sound may be present in cases of predominant mitral incompetence and absent in tight stenosis with rigid valve cusps. The intensity of an opening snap is thus no indication of the degree of stenosis, but the interval between the opening snap and aortic valve closure, which can be measured on a phonocardiogram, may be useful in this assessment. The interval is short in tight mitral stenosis and relatively long in mild cases. Here is an example recorded at the left sternal border of a patient with severe mitral stenosis and a loud, close opening snap. Measured on the phonocardiogram, it occurs 0.06 seconds after A2. The first heart sound is the loudest sound and is preceded by a presystolic murmur. Another recording of the same patient, taken at the apex, shows all the signs of pure, tight mitral stenosis in sinus rhythm and with a pliable valve. The first heart sound is loud and snapping, systole is silent. The opening snap follows closely on the second heart sound, and then the rumbling mid-diastolic murmur is heard, which fills the whole of diastole and terminates in a presystolic crescendo. The next recording illustrates a less severe case of pure mitral stenosis. The mid-diastolic murmur fades off in late diastole, and the interval between A2 and the opening snap, although difficult to assess clinically, is 0.08 seconds. In atrial fibrillation, there is no presystolic murmur, as this results from atrial contraction. But in tight mitral stenosis, the diastolic murmur still extends right up to the next first heart sound. This 52-year-old woman is fibrillating but has tight mitral stenosis with a pliable valve. The first heart sound is loud and varies in intensity. A loud opening snap is heard following the second heart sound, and then a rumbling murmur which fills diastole. To facilitate recognition of the sounds, this recording will now be slowed to half the previous rate, and then played again at the normal rate. Here now is an apical recording of a patient with a short mid-diastolic murmur preceded by a soft third heart sound. The dominant lesion is mitral incompetence. A third heart sound is incompatible with significant stenosis, as it depends for its occurrence on rapid ventricular filling, and under these circumstances this cannot occur. Functional mid-diastolic murmurs are common and may be present in aortic incompetence, in congenital heart disease such as patent ductus arteriosus and ventricular septal defect, or in hypertension, heart block, and high output states. In some instances, differentiation from organic mitral diastolic murmurs may be difficult, but associated signs such as a loud mitral component of the first heart sound, definite presystolic accentuation of the murmur, or a regurgitant systolic murmur of mitral incompetence would favor disease of the valve. The presence of an opening snap would signify definite abnormality of the valve. This recording is of a functional apical mid-diastolic murmur in a 12-year-old boy with large left-to-right shunts through a ventricular septal defect and patent ductus arteriosus. There is no presystolic accentuation or opening snap. The pansystolic murmur of the ventricular septal defect is also well heard at this site. The most characteristic feature of tricuspid diastolic murmurs is their increase in intensity with inspiration. They are often low-pitched and rumbling, resembling a mitral diastolic murmur, but sometimes have a scratchy quality. An opening snap arising at the tricuspid valve may be difficult to differentiate from a mitral opening snap, but may be noted to become louder and earlier with inspiration. However, this would usually need phonocardiographic confirmation. The next recording at the lower sternal border of a 55-year-old patient with both tricuspid stenosis and incompetence illustrates the marked respiratory variation of tricuspid murmurs. The first heart sound is fairly soft. There is a grade 2 blowing pansystolic murmur and a fairly long diastolic murmur.
In, out, in,
Here is another example of tricuspid stenosis with associated incompetence in a 14-year-old girl. The diastolic murmur in particular increases markedly on inspiration, and the first part of the murmur becomes higher pitched and rather squeaky.
out, in, out, in,
Functional tricuspid diastolic murmurs, which are due to increased flow across a normal valve, are usually present in left to right shunts at atrial level, but may also be associated with functional tricuspid incompetence. They are often loudest in presystole and have the same crescendo-decrescendo shape as organic murmurs. Listen again to the recording of the 14-year-old boy with an atrial septal defect, and concentrate now on diastole to hear the scratchy tricuspid murmur which is recorded at the lower sternal border. Continuous murmurs occupy the whole of systole and pass through both components of the second heart sound into diastole. The murmurs are due to continuous flow of blood from a high to a low pressure area, and their duration is therefore dependent on the relative pressure differences during the cardiac cycle. The so-called machinery murmur of a patent ductus arteriosus is an example of a continuous murmur. This recording, taken at the pulmonary area in a 15-year-old girl, shows the murmur passing through both components of the second heart sound. The first heart sound is not heard. Here is another example of a patent ductus arteriosus in a 24-year-old woman. The recording is taken in the second left interspace, and the second heart sound is well split during inspiration and nearly closed in expiration. The first heart sound can only be heard during expiration.
In.
In the third left interspace of the same patient, the machinery character of the continuous murmur is even more apparent. A third example of a patent ductus is that of the 12-year-old boy whose pansystolic ventricular septal defect and functional mid-diastolic murmurs were heard previously. The recording is now taken at the pulmonary area. Both components of the second heart sound are increased in intensity, A2 due to an associated coarctation of the aorta, and P2 because of the greatly increased pulmonary blood flow and moderately raised pulmonary pressure. Other causes of a continuous murmur include venous hums, pulmonary and systemic artery stenoses and arteriovenous fistulae, ruptured sinus of Valsalva, aortopulmonary window, and coronary cameral fistula. A continuous murmur may also be heard over large collateral vessels, for example bronchial collaterals in pulmonary atresia and the so-called mammary souffle of pregnancy. The final example is of a continuous murmur in a 5-year-old girl with pulmonary artery stenosis. The first heart sound is inaudible, and the murmur extends through both components of the second heart sound into diastole. A sinus arrhythmia is present. In the third left interspace, only the louder pulmonary component of the second sound and the continuous murmur are heard. In conclusion, it must be emphasized that we have been compelled to deal only briefly with the theoretical aspects of heart sounds and murmurs. A list of recommended references is provided on the cover for those who wish to investigate this interesting subject more intensively.